My name is Scott Kopetz. I'm a GI medical oncologist at MD Anderson and the deputy chair of our department and focusing on clinical research.
Thank you very much. So one of the things we want to know is for patients that are currently on a clinical trial, what advice do you have for them? You know, we've been hearing a lot that there's a possibility some patients may have to pause their treatment or completely come off a clinical trial for that reason.
Yeah, and I think it's been heartening to see, the kind of community come together and just recognize, the unique nature of this situation. As you and many others know, clinical research has not always been known for its flexibility, right? You've got to be there at a certain time and a certain day and get this test done and this one, and there's no deviations, allowed. But I think what we've seen is both the level of the investigators, at the level of the treating centers, as well as the sponsors, if there's a pharmaceutical sponsor, there has been a lot of flexibility in this regard. And I think, we're just recognizing that the most important thing is to really do what's in the best interest of the patient, to try to, maximize the benefit that comes from being treated on a clinical trial, but also recognizing that we don't want to increase the risks to the patient. And so that's been the guiding principles for a lot of them. And I think we're seeing a number of trials adapt in different ways to try to address that.
Great. Well, thank you for that. And so on a similar note, I would ask you, what advice do you have for patients who are hoping to enroll in a clinical trial or potentially were, approved for a site, but now that site is putting all hold on new studies or pausing new recruits?
So this is one of the hurdles. I think while on one hand, there's a lot of flexibility on patients that are on study to try to keep them on, to be creative in ways to try to get drug shipped, to waive visits, to forego extra research tests that normally would have been done. At the same time, there's a reticence to enroll patients into new studies in general. And we're seeing this in various different ways. Some centers are kind of fully shutting down research, which is just kind of across the board, and as we speak now, it's, for many areas of the US still a few weeks away from our peak of COVID. And so the thought is, until we really understand what this peak is going to look like and the impact on the healthcare system, that we're really trying to do a short-term pause, a few weeks of pause of enrollment. For other centers, there are still some that are enrolling because they're just not seeing much yet in the community, but I suspect a lot of those are going to be shutting down here over the next few days, if not week, as the numbers ramp up. I think what we are seeing is that there are select studies where we're still kind of continuing, enrollment and still trying to find that right balance of kind of risk benefits. So some settings where there's clear activity of the agents and where there's not a good standard of care option available, or where the study itself is really trying to ask, can we de-escalate therapy safely? And we think that the results look encouraging, where, not only would it be a benefit from continuing the study, but also less engagement with the patient and the healthcare system, which may reduce their risks. So these type of things that we're trying to select, but those, at least in our center, and I think many of my colleagues' centers, those are 5% of the studies or less. That the majority of studies really aren't enrolling. There are some sponsors who actually have kind of come across with a blanket statement, right? Who have just said, and by that I mean, the pharmaceutical companies have said, until you can, ensure that we're getting all the blood tissue data safe, until we can ensure the safety of the patient fully, they're kind of making a decision at the sponsor level to halt that. And so we've seen that in a few pharmas, kind of just across the board. We're going to kind of shut down trial enrollment for the moment. So there's some variability there. And I know that makes it very difficult for patients who are trying to navigate what's open, what isn't. Is this shut down nationally? Is this shut down at my local center, or what's available elsewhere?
And what would you recommend to them if they're, I mean, is it best for them to reach out to the clinical trial coordinator, or will the clinical trial coordinator be in contact with them? I guess, how do they weigh those benefits?
Right. So our recommendation is that is that this is a very difficult time to travel to receive treatment under clinical trials, and so it really is kind of what's available locally for you. And I think we in many centers that are traditionally referral centers have really substantially shut down the ability of patients from out of state or out of region to come in based on some of the guidance from the public health officials in the state or the region. So there are some limits to that as well. For example, in Texas, where I am right now, at the moment, there's a 14-day quarantine for anyone coming from out of state, right? So even before they can even come to see me, if they're coming from out of state, they have to come into Texas, wait 14 days in a quarantine somewhere in a hotel, presumably, and then come in to see us. So that just really isn't feasible for most patients.
And so your labs and your research has been shut down in person. So how are you all pivoting, and what kind of changes have you made?
Right. So, some of the most devastating impacts has been on the basic science, the lab research. So we've, and almost all academic institutions have fully shut down the labs. So this is more than just turn the lights off and going home, but experiments that are many months in the work have to be discontinued. The animal experiments have to be ended. We're still have somebody going in and feeding the animals and keeping the mice happy and things like that. But there's a lot of disruption there. Similar with clinical research, I think the clinical research nurses are trying to do all of their research remotely. So they've actually been banned from coming into the campus. So they say that you've got to stay home, do what you can remotely. The only clinical trials that we're allowed to continue to enroll to are ones that can be safely done remotely by the research staff. So the physicians there, the patients there, everyone else is at home and calling in on FaceTime or on teleconferences on phones in the room. And we've been able to continue that, but that there's certainly barriers that come out of that remote monitoring and remote care.
I guess I just have two more questions for you. Is there anything that I haven't asked you that relating to like clinical trials and treatment or care that you think patients should know, or that you've been hearing from your patient community that we should share out with?
Yeah, no, I think part of it is kind of working with your oncologist to understand what's the right risk and benefit. And in general, for whether it's clinical research or our standard of care treatments, we're really trying to balance the intensity of the therapy with the increased risk. Part of it is, to be honest, we still don't fully understand the risk to cancer patients from COVID. So the data out of China was small numbers, was fairly daunting. I suspect in the next few weeks we'll get some additional data from the US that will help with that. But we've gone into this saying, if the data from China is correct, it means that patients on chemotherapy, especially more intensive chemotherapy, are substantially higher risks of complications from COVID. And so this is probably the the key part that's driving a lot of the decisions to really say, where instead of triplet chemo, where can we do doublet? Instead of doublet, where can we do single agent or even oral chemotherapy to temporize? Or, we're in a situation where your cancer's under control, and maybe we take a break for a month off of that. And so we have a lot of patients that we have that conversation and say it's okay. And I think just acknowledging that that you know, as your oncologist is really trying to balance this difficult duality of trying to minimize the risk for you as a patient from the COVID infection, which is a really bit of an unknown, with the kind of fairly modest impact, if any, of these kind of chemotherapy changes. So I know it can be really scary, right? It can be really uncertain when you were told you've got to do 6 months of adjuvant chemotherapy, and then you come in after 4.5 months and the doctor's saying, well, I think we should stop now, because of the risk from COVID. And, you're set on 6 months, but in those situations, absolutely, that's probably the right thing to do. The incremental benefit, if any, of that last, month and a half of treatment versus the potential risk of being on chemotherapy over the next 6 weeks it really favors stopping therapy. So this can be very disruptive, I know, to patients and their expectations, and the anxiety levels can absolutely rise, understandably, through this.
Awesome. And I have one final question for you that I would love to end with. Do you have any words of encouragement for our patient community, and what would you say to them?
Yeah, no, it's a great question, and I'd say, this will pass. We'll make it through this, and I think, we recognize that that well-oiled healthcare system that you're used to is really been turned upside down, and I know that's a lot of disruption for you as well. But this will pass. I think we will get back to normalcy. I think the impacts of what happens over the next month or 2 or 3 are not going to have a major impact on patient outcomes in the long term. That I think trying to find that right balance is absolutely okay. And I guess to just ask to continue to have that trust and faith in the oncologist, that even though these recommendations may be a little anxiety provoking, that we really are trying to find that right balance between what's going to be best for you. So we're all in this together, and I've no doubt we'll make it through the other side.